Thank you, Susan. So, yes, I'm the only person keeping you from lunch, so I do apologise for that. But what I am going to talk about is about non-invasive ventilation in motor neurone disease, the clinical treatment that I've been involved with for years, and many other people like me, and the thing that we've done the most research into. So, one thing that will help get you to lunch early is that much of this has already been covered by others, so I will skip over the data that we all put in our slides about motor neurone disease. But I will stop at the picture that you have seen previously, and which is conveniently emerging of a couple of people's other slides, just to highlight this word that Susan spoke about at the start, about heterogeneity. So when we're dealing with non-invasive ventilation, what that means is a machine and a mask to help people breathe as much overnight as they do during the day. So when we use ventilation to help somebody with their breathing during sleep, the idea is not to push more oxygen into them, it's just to stop the normal drop in breathing that we all experience overnight. So when all of us go to sleep, our level of carbon dioxide, the waste product we produce, goes up a little bit. But then in the morning we get up and we've got strong muscles and normal arousal responses, and we blow it back down and you never notice. But when you're weak, when you've got weak muscles, you can imagine that your ability to do that drops. And so where we see abnormalities in people's breathing levels is first during sleep. And so that's why we attack it during sleep. Not really because there's anything magical about breathing in sleep, it's because you're asleep and you're not doing anything else. And we can fix it then, and you'll feel better during the day. So those phenotype classifications have different types of breathing problems. And these contribute to survival in motor neurone disease. So the groups with respiratory failure is the usual cause of death for most people with motor neurone disease. And so the groups that have the most difficulty with breathing are, not surprisingly, the people who die quickest after symptom onset. So I'm going to show you just a couple of pictures of what we measure when we do sleep. So this is a sleep study. So I'm going to take you through this because I think it's really cool. But they are nice illustrations of what a night looks like. So this is a night spent in a sleep lab. This is the power spectral analysis of what your brain looks like. So this is a person living with motor neurone disease who had come along to see us at about the time where they've got enough impairment, so we think that giving them non-invasive ventilation will make them feel better. One of the ways we can see that is this, which is this is highly compressed, obviously. This is a whole night's sleep. But each one of these little vertical black lines is an arousal from sleep. So it's somebody being woken up by not being able to breathe enough to stay asleep. These are the respiratory events that we've categorised and counted. But the thing about it is that it's all just a bit scratchy and yucky looking. If this person, you'll see on the next slide what good sleep looks like, but this is the yellow and the green are light stages of sleep. And REM sleep, your dreaming sleep, is nowhere to be seen in this person. And it's not just because we put them in the sleep lab and covered them with wires. The other thing is that their oxygen is dropping down where they're asleep and going up and down, and their level of carbon dioxide, which I talked about before, is this straight line, and you can see how it goes up and it just stays up overnight at a level that we think is abnormal. And then NIV magically fixed the person. So this is after we've been able to work out what kind of machine is best for them, what kind of mask is best for them. Typically, certainly in Victoria, you come in during the day, we'll set you up, send you home, acclimatise to it, and then we'll check how you're going. And this is what it looks like. In this case, this was a fairly early sleep study. But this red stuff is the REM sleep, and you can see that there's tons of it. And that's what happens. When we fix your breathing overnight, you sleep a lot better. There are very much fewer arousals, and there's this nice consolidated chunks of sleep. So this person has gone to sleep and has stayed asleep, which is very different from what you saw before. And I suppose to give you some context about how this feels, those of us who've had children remember that great time early on when you were awake all the time, it seemed. That's what it's like to be living with a sleep disorder. Anyway, so this is what we do, and this is what we have done for a long time. There's a bit of research, but not as much as we'd like, about how this works. The ALS FRS scale, many of you will know, which is a way of categorising how far your ALS has, MND has progressed. And so the people in this study before the non-invasive ventilation continued to have their disease progress. It didn't stop their motor neurone disease. But what these data shows is that on a sleep quality of life measure and what we call a generic quality of life measure, going on to the NIV relative to your baseline bumped you up. And this is how we think about it. It takes you from where you were at the start and pops you up for an extended period of time. Now, this same person, Stephen Burke, many years ago now, did the one randomised controlled trial we've got, which justifies the use of non-invasive ventilation. And it's great that we've got a trial that proves that, but it's actually quite small, and it's not quite as conclusive in some ways as we thought it was. So it's only a study of 40 people. And within that 40 people, there were two groups. There were people without significant bulbar dysfunction and those with bulbar dysfunction. Now, these are what are called Kaplan-Meier curves for people who haven't seen them. They're a way of estimating not estimating, rather showing the likelihood of survival with treatment A or treatment B. And so overall, there is an advantage in survival with non-invasive ventilation, which is why we all use it. But when you come down to the groups that are split in half, which as I say are quite small, you can see that one of the conclusions of the study was that in people with bulbar disease, it wasn't worth it because there wasn't a big enough difference in survival for it to be worthwhile. And in the non-bulbar group, there's a big separation between these lines, which is statistically significant. But each one of these dots is death or censoring, so death in this case of people in the trial. And you can see that in the group that were randomised to not get NIV, 4 of them were dead in the first week. So subsequently, we've come to think that this difference is actually just chance. Every time we do an experiment, there's a chance we can find something that's not true. And it does seem that this may well have been chance. Chance on the good side, but still chance. So one of the consequences of this study was that even though practice guidelines tended to suggest the benefit with non-invasive ventilation was not as large in people with bulbar dysfunction, a lot of us just didn't believe it around the world, and so it continued to be offered to patients who could tolerate it. So what we wanted to do many years ago now, Susan and Paul Torman and myself and a guy called Lou Irving, who was the head of our medical leader of our unit at the time, we started trying to look at what was the effect of non-invasive ventilation on these various phenotypes on survival. So we got together and got some data and started collecting things. So we published this first paper a couple of years ago from this. So this is, almost 15 years worth of prospectively collected data with a little bit before that, all quite patient and stubborn, where we had data on almost 1,200 people, and we were able to include 930 people into the final analysis to see what this effect was. So this is not a randomised controlled trial. It's really important to say that this is an exploration and a description of what happened to this group of people. So everything you see here has to be viewed through that prism. So there are differences in the people who chose to use NIV or chose not to use NIV. We can talk about where those differences might come from at another time. Most people did not go on to NIV over this period, and those that did tended to be younger, were more likely to be male, were more likely to have had riluzole and PEGs, but the pattern of disease between the two groups was about the same. It certainly wasn't significantly different. But what we found when we did those Kaplan-Meier curves and the other analysis is that those people who were able to use non-invasive ventilation had a median survival, so not the average survival, but the survival in the middle, which is the best estimate for this sort of stuff, that was double almost those who didn't use non-invasive ventilation. That's what the Kaplan-Meier curve looks like with, and this is locked at time 0 in this study, is from the date of symptom onset. So when people first remember having trouble with speech, or when they first dropped something or tripped on a rug or something like that, not from diagnosis, because as many of you will well know, it can take a long time to get to diagnosis for various reasons. When we looked across the phenotypes, the biggest survival advantage, which was statistically significant, was actually in the Bulbar group. So, well, it's clearly heresy because it's vanished. The group of people with bulbar onset disease actually benefit if they can tolerate treatment, if they're up for it and they can tolerate treatment, their benefit in terms of survival is by far and away the largest. Now this is on what we call univariate analysis, where we're just looking at this benefit, but you can imagine there are things that confound this. There are things that complicate it, like are you using riluzole? We know if you're older, when you get a diagnosis of motor neurone disease, your survival is different. There are gender effects. So we control, these are the Kaplan-Meier curves, which just show pictures that show the same thing. And when we go back and control for all of that, we still have this significant effect overall, and most of the significant effect is attributable to people with bulbar onset disease. 0.05 is the magic number that we use for cutoffs, so lumbar onset and flail limb kind of fall out when you control for PEGs, riluzole, age of onset and gender. There was also kind of a step change in our practice around the country in 2003, which was associated with riluzole. So in this regression is kind of an on-off around that. Now, we're not orphans. Other people around the world in smaller cohorts have been able to demonstrate a similar kind of thing. And in particular, I just want to highlight this one, which is quite old, but we have evidence from other diseases now that how much you use ventilation matters. 4 hours seems like a bit of a magic number. If you get past 4 hours use overnight, you're much more likely to be symptomatically to feel better. And if you get past 4 hours a night, you're also much more likely to have changes in the kind of chemical control of your breathing overnight. So a bigger reduction in carbon dioxide, a bigger improvement in the amount you can breathe up for a stimulus. So, how does this work? So it doesn't, if you then stop and go back and go, well, how does just stopping me not breathing overnight, not under breathing overnight, double survival in some case? You know, that would tend to suggest that at some level it's actually modifying the disease. Now, we don't have a lot of good answers for exactly why, but there is two labs that have looked at this at a cellular level. And one of the best ways, reactive oxygen species are bad in motor neurone disease. One of the best ways to produce reactive oxygen species is to give you chronic intermittent hypoxia. So when you drop your oxygen level, your cells starve, but then more damaging is when you wake up and all that oxygen floods back in, you get these reactive oxygen species occurring throughout the body. So there are data that have been published in the sort of best characterised animal model of what 12 hours of chronic intermittent hypoxia does, and it does all kinds of badness at a cellular level. And so this is what we're hypothesising is actually potentially the driver of the survival benefit in many ways, is that we make this less bad by taking away the potentiating effect of chronic intermittent hypoxia. So really in conclusion, what we can say from this very big cohort is that NIV is good and we should probably use it. The people with bulbar onset disease, if they're able to tolerate and the whole, the family, the environment, everything is set up so that they're able to tolerate it and use it well, it will help. It is not futile. It is harder for a clinician to do, but that's okay. That's what you pay us to do. I didn't show the data, but we also see a similar reduction in the rate of decline in the lung capacity over time, which mirrors all of this. So it does work. It should also always be considered. It needs to be incorporated into practice, and we're going to do some work around that. And just lastly, I want to thank people who gave us money over the years, Susan and Paul, and for those of you who know Paul, he's always telling you things, and all of the team from the VRSS. That's now an old photo. I try never to wear a tie. Thank you very much.